Well, this is Dr. Nolan today. I hope you're having a good day. Today's discussion is going to be on fluid and electrolyte disturbances. Remember, we've recalled this discussion before in physiology and part of pathophysiology that the actual distribution of body water content is that approximately if you take 100% of the total body weight, 60% of the actual total body weight is actually water. So we're basically essentially a large bag of water. Intracellular content of that total body weight is actually 40% of the actual volume. The extracellular space accounts for about 20%, and the extracellular space can actually be broken down into the interstitial space, which accounts for 15% total body weight, or 5% of the intravascular space. The way I look at this myself is that I imagine that there's boxes where the fluid is contained. If you look at the actual single red box that you see in this pyramid shape, that's your total amount of blood that's contained in your blood vessels. So we only have essentially one box of actually volume that's contained in the space that can possibly hemorrhage out rapidly. There's three boxes that contain the interstitial space, if you look at the numbers beyond that, is that if you take the four boxes together, interstitial space plus intravascular space, you can then double it, and that would be the amount of extracellular space. So that's a way I do it in an analogy to basically think about how much volume is inside of a normal patient. The actual normal amount of volume that we actually work with when we're talking about laboratory tests, though, is that we're only testing usually the plasma space, which is the intracellular, intravascular space, not the intracellular space itself. Now you do have to know, just like we talked about before, the actual different electrolyte composition between differences between intracellular and extracellular content. Remember that the sodium electrolyte concentration inside the plasma is actually fairly high. It's 140 milliequivalents, as well as in the interstitial space, which is very similar, like 145. But when you're talking about intracellular, sodium is being actively pumped out by the sodium potassium ATP pump. So as a consequence, the actual sodium concentration inside the intracellular area is very low. It's around 10 milliequivalents per liter. On the other hand, potassium is in the reverse side. Remember, potassium is being pumped into the cell. The actual normal vascular content is around 4 to 5. The interstitial content is about the same, and the intracellular fluid is very high at 150 milliequivalents per liter. The other higher contents of calcium, magnesium are high in the vascular space. Magnesium is one of the exceptions in the sense that it's also very similar like potassium in very high concentrations inside the cell of around 40 milliequivalents per liter. Chloride is found in high concentrations in the vascular space and the interstitial space, but in very low concentrations in the intracellular space. The bicarbonate is also higher in the extracellular and interstitial space in comparison to the intracellular space. Now, there's different organs that basically need different combinations of electrolytes. We know that in the brain, essentially, sodium is very important and a sense of very fast channel opening. They're important for very fast conduction. Not all cells have fast sodium channels like this, where the other place where you find fast sodium channels, of course, are in conduction regulators such as pacemaker cells. Sorry, not pacemaker cells, but cardiac muscle cells. Other areas of the body are not as high in density with fast sodium channels. The other place where you see sort of similar to fast sodium channels will be all the axons that are peripheral nerves can also contain the fast sodium channels. Brain is also very important for having high levels of potassium, intracellular for helping for repolarization, and also calcium is very important for neurotransmitter release. As for cardiac pacemaker cells, the sodium is not as critical. You don't have fast sodium channels found in cardiac pacemaker cells. Potassium still remains important for repolarization, and it's pretty much found in any muscle cell that you talk about. Calcium is also important for conduction, If you look at cardiac myocytes, you remember that you need the fast sodium channels for these, and calcium is very important for its actual contraction ability. Potassium is also important for its repolarization. Smooth muscle and kidney, again, they have their own different needs. Just so that's one thing I want you to sort of think about. Think about the individual organ system when you think about electrolytes. If you look at the electrolyte content for bodily fluids, and these are important more so if you're causing drainage of these fluids. Specifically, I want you to pay attention to is the amount of gastric fluid when you have low pHs. The actual gastric fluid content is fairly high in sodium. It's also very high in potassium and chloride, and almost has no bicarbonate left. On the other hand, if you look at the actual pancreatic ileal fluid, colonic fluid, is enriched in bicarbonate. So if you have forms of diarrhea or pancreatic diseases, you can lose a considerable amount of bicarbonate and make the patient acidotic as a result. One of the things that I do recommend that you study for this exam, because I'm going to answer several questions on this, is the content of electrolytes solution concentrations. I'll be asking you how much sodium is normally present in normal saline, which is 0.9% sodium chloride, which is 154 milliequivalents of sodium as well as chloride. And also know that there's no potassium in the solution as well. The other important solution that you should know about is lactate ringers, which has lower amounts of sodium, around 130 milliequivalents per liter, and chloride's more around 109, and with the potassium included in it, 4 milliequivalents per liter. So in essence, patients with renal failure should not be given lactate ringers as they begin to accumulate excessive amounts of potassium as a result. The other thing that lactate ringers contains is high doses of calcium, which is around 3 milliequivalents per liter. That calcium would make it contraindicated to use in patients that are receiving blood transfusions through the same line. The calcium inside the lactate ringers would cause the red blood cells to stack formation, which is called a rouleau formation, R-O-U-L-E-T-T-E. So rouleau formations will not be really seen on your IV line, but when they get into the bloodstream, may actually cause problems with DIC or issues with like in the lung where it begins to concentrate like an ARDS. The actual approximate pH in all of these solutions is mostly slightly acidotic. If you look at lactate ringers, the acid levels, there's a pH of 6.6. The only time that's not necessarily the case is a fluid called Plasmolite. Plasmolite is really a nice solution because it's very similar to your actual plasma. That's why it's called the terminology of Plasmolite. It actually has almost all the essential nutrients, essential electrolytes for your body. It's got sodium levels that are normal, 140 milliequivalents. But the chloride's actually fairly normalized to at 98. Potassium is a great replacement, and it's 5 milliequivalents per liter. It also has magnesium, which is 3 milliequivalents per liter. One of the few actual crystalloids that has that, and it contains no lactate. And the actual approximate pH is normalized at 7.40. So it's one of those great IVs if you can give it to somebody. It has a milliosmolarity of around 295, which is pretty much normal. So this is about as close as you can get to using anything that would be more normal to the person's plasma concentration. The reason that we don't tend to use Plasmolite as much is because its expense. I think it's like 10 times more expensive than the lactate ringers or sodium chloride. So questions you got to ask yourself, because we're trying to make these things practical, is that which type of fluid should you give? How much is too much? And I'll be asking you on the exam pretty much how you treat hyponatremia. What are the solutions that will cause hypernatremia? Like if you give somebody normal saline with 154 milliequivalents per liter of sodium and chloride, you would expect that the person would develop hypernatremia and hyperchloremia. Also expect you to know what solutions could be used for renal failure patients, which would be normal saline, and that you'd avoid things like Plasmolite or lactate ringers in these individuals. And then how do you actually treat hypokalemia and hyperkalemia? in clinical situations. Remember that regulation of sodium balances. If I go back to this discussion with the kidney function, the proximal tubules absorb around 65% of all the sodium that's filtered, and then the rest follows through different portions of the loop of Henle. Ultimately, what regulates sodium regulation is due to aldosterone. If you increase levels of aldosterone, you increase the levels of sodium reabsorption. Things that will actually decrease sodium reabsorption are things like H1-natritic peptide, which then allows water to go out, and the person will basically lose volume with high levels of A and P. Regulation of water balance is still highly regulated through the actions of the hypothalamus and the pituitary gland, the posterior pituitary, which is antidiuretic hormone. You guys are going to keep talking about this in the endocrine lectures, so I'm not going to go over this in more detail. And just understand that ultimately aldosterone, as well as and antidiuretic hormone, begins to affect the ability of sodium levels. Aldosterone, of course, is ultimately the one responsible for increasing sodium reabsorption, and it's activated by the renin-angiotensin system, like we've discussed before. The action of antidiuretic hormone on the distal tubules is that they basically affect sodium reabsorption through the actual distal tubules and causes more retention of water as a consequence. So antidiuretic hormone is actually a pretty potent agent that's usually released due to elevations in sodium levels in the body. So the body's trying to regulate the amount of sodium content by pulling more water back in. The other agent, of course, is H1-natritic peptide, which is released due to overdistension of the atrium. This causes an inhibition of sodium reabsorption in the proximal and the distal segments of the collecting tubule, and as a consequence, water begins to be formed more in the urine. As a consequence, a person forms more of a dilute urine with elevations in H1-natritic peptide, as a consequence causing diuretic-like effect. Factors that stimulate antidiuretic hormone release are things like contracted extracellular fluid volume, hypernatremia, like I talked to you about before, hypotension, nausea, vomiting, patients that are developing congestive heart failure, cirrhosis, hypothyroidism, angiotensin II levels that are elevated, catecholamines, which indicate stress, histamine, bradykinin, also drugs that also cause increased levels of ADH with increasing fluid retention are things like tricyclic antidepressants, barbiturates, some of the anti-epileptics, and narcotics such as morphine. Nicotine also helps stimulate ADH release, and some of the other phenothiazines as well. Factors inhibiting ADH release are expanded extracellular volume, hyponatremia, and hypertension. As for hyponatremia, this is a diagnosis of a sodium of less than 136 milliequivalents per liter. Usually at that point indicates that possibly the plasma osmolarity may be in hyponatremia in either high, low, or normal. And the most frequent one, of course, is dilutional, where the person is taking an excess amount of fluid in comparison to the amount of sodium content. Remember, when you're thinking about this, that you have essentially 136 molecules of sodium sitting inside 1 liter of contained solution. That's what should be your normal values. Normal values usually is around 140, but once you get below 136, it's considered hyponatremia. If you actually decrease the actual total number, and you may actually cause the osmolarity to change as a consequence because it's a concentrating ability. If you look at hyperosmolar hyponatremia, is a hyperosmolar intravascular effect is to pull water from the cells and the interstitial space, causing a hyponatremia due to dilution. There's basically two causes of hyperosmolar hyponatremia. That's when you add osmotically active compounds, which are unable to move from the intravascular space to the interstitial space. Things like high levels of glucose mannitol, or in like in TERP procedures where you're giving glycine. Glycine may also act as a agent that causes hyperosmolar or hyponatremia. The other way you can actually cause this effect is by increasing the solid phase in the plasma, which we call a pseudohyponatremia. Things like elevations in high levels of lipids in your bloodstream, such as hyperlipidemia, and or very high levels of protein, which is called paraproteinemia. On the other hand, the other form of hyponatremia is called hypoosmolar, also called dilutional hyponatremia in many books. It's the most common form of hyponatremia that we usually encounter, and there's three categories basically of hypoosmolar hyponatremia. The first one is hypovolemic hyponatremia, which is where water and sodium are both lost, so this person's in a dehydrated state, but they're losing more sodium than the amount of water they've lost. The second form of hyponatremia is euvolemic hyponatremia. And this is also a hypoosmolar effect where you have total body water content actually increases without the really significant change in sodium content. And the last one of the hypoosmolars is the hypervolemic hyponatremia, and it's basically both sodium and water content increase, just that the water content increases more dramatically than the sodium content. As a consequence, you have these different forms of hypoosmolar hyponatremia, as you can see on this graph. If you look at the hyponatremic, hypovolemic patient, you see a decrease in skin turgor, flat neck veins, a dry mucous membrane, and usually these people are orthostatically hypotensive. If you have urine sodium ability that's greater than 20, that would indicate renal losses as being the major source of the hypovolemia. This is usually from diuretic therapy, mineralocorticoid deficiency such as aldosterone deficiency, salt-losing nephritis, renal tubular acidosis. Forms of metabolic alkalosis can also cause this, as well as ketonuria and osmotic diuresis. If you see that the kidney is trying to retain sodium, then you're looking at extrarenal losses that are really causing this. This is somebody who is actually could be causing from nausea or vomiting. It could be from third space losses, burns, pancreatitis, or muscle trauma. On the other hand, if you have patients that are euvolemic, again, you can either decide if it's the sodium by checking the urine sodium, if it's concentrating versus non-concentrating. If the urine sodium that's less than 20, then it's usually a salt-restricted diet that you're seeing. So on the other hand, if you're seeing greater than urine of greater than 20, it's from loss due to glucocorticoid deficiency, hypothyroidism, SIDH, and sometimes due to high sympathetic drive. As for hypovolemic hypoosmolar hyponatremia, these people usually develop significant amounts of peripheral edema. They'll develop pulmonary edema, such as when they get roused. They also may see ascites. There's again two forms of it, which continue the diagnosis. Either it's salt retaining, like in this situation, or salt wasting in the urine. If it's salt wasting, that it's due to renal losses, and it could be from acute renal failure or chronic renal failure. If you're doing it from rapid concentrating abilities, then it's from avid sodium reabsorption. Things like nephrotic syndrome, cardiac failure, or cirrhosis can be account for this. Hyponatremia signs and symptoms primarily central nervous system is ultimately important for rapid sodium effects. Remember we talked about this briefly in the previous slide where we talked about how certain signs or organs are more sensitive than others. In this case, with sodium being a very important electrolyte for brain function as well as peripheral nerve function, patients will become increasingly confused. They will develop this generalized malaise. They'll develop anorexia, nausea, vomiting. If hyponatremia gets very severe, it will actually induce seizures and even coma and death, including respiratory arrest. If the hyponatremia occurs too fast, it actually may cause brain to actually develop herniation. It has, of course, because of the decreases in sodium channels, the activation of neurons become depressed, and as a consequence, you have decrease in neuronal excitability. You may also begin to affect myocardial cells at very low levels of sodium, causing myocardial depression and significant muscle weakness. If you look at one example of, let's say, your euvolemic hyponatremia, where you see that your urine sodium concentration is greater than 20, which means that you're spilling sodium in these individuals. It's a situation like in syndrome of inappropriate antidiuretic hormone. This is leading to an increased reabsorption of free water in the renal tubules, and it causes an increase in total antidiuretic hormone. These people are usually have possibly cancer or have pulmonary problems such as acute respiratory failure, or can also SIDH can occur just from simply positive pressure ventilation. Central nervous system wise, it could be from post-op pain, stroke, or endocrine hemorrhages. Things like drugs that actually induce SIDH are things like desmopressin, oxytocin, the tricyclic antidepressants. Your actually serotonin inhibitors is all opiates, and then some of the chemotherapeutic drugs such as cyclophosphamide and vincristine. Treatment of hyponatremia of all types, you need to basically identify the cause, and you have to identify how severe it is. A lot of these will actually tolerate withholding free water. That usually includes fluids, unless the person is dehydrated. In that situation, you want to replace the fluids appropriately. If the person is euvolemic or hypervolemic, loop diuretics also work, but it's not appropriate for patients that are hypovolemic. The other treatment is sometimes giving 3% normal saline plus Lasix furosemide, but I would only give those to those people that are very severely hyponatremic and are becoming symptomatic. Do not basically increase your plasma sodium concentrations by basically greater than 0.5 milliequivalents per hour unless the patient is seizing or in coma. Aggressive overtreatment may actually risk the patient developing what's called central pontine myelinations, or what's called the central pontine demyelination syndrome. What I would recommend at that point is to put an A-line these individuals and draw your labs frequently, and that way you can monitor very closely your sodium levels. An interesting study was done a number of years ago where patients were found that if they were getting severely hyponatremic and were not treated, they would get into seizures and coma, and would have had very, very serious after effects. One of the things that they began to try to treat this problem with was replacing with 3% normal saline. And unfortunately, what they did is when they treated these individuals, the patients stopped their seizures almost immediately and started responding appropriately. And at that point, they continued infusing this 3% normal saline for too long a period of time. And actually, 2 or 3 days later, the patient would then develop seizures and coma again. And what they would actually be the cause of that is that the actual sodium levels would be rising rapidly in these individuals, and maybe was causing the central pontine myelinitis. So one of the things that you have to consider is how fast you want to replace the sodium, and the answer is it's appropriate to replace the sodium in conditions where you're actually having seizures and coma. But once you get out of that phase, then you should kind of go ginger and kind of ease up on your sodium replacement, so you tend to overcorrect and causing demyelination syndromes in the central nervous system. The osmotic demyelination syndrome causes things like pseudobulbar palsy. The patients will develop basically what's called the lock-in syndrome, where they develop quadriparesis, which means all four extremities will lose their ability to be activated. They may also have milder forms where they get movement disorders. These people very often will have persistent behavioral disorders, seizures, and you may not see these damage for up to 1 to 7 days after treatment. So what happens if you have clinically a question? Like, what happens if somebody comes in and is seizing and you need to take them to the operating room because they have some other operational requirement? So how would you treat this? And the answer is it really is appropriate to treat them aggressively at that point initially. I would recommend you put an A-line right away, check out your sodium levels as your baseline, and then begin to treat. What's usually recommended is giving either 50 cc's of 29% normal saline over 10 minutes. This is basically contains around 17 milliequivalents for 0.1% normal saline. So if you're looking at 29%, then you're looking at 17.1 milliequivalents times 29%, which is basically 499 milliequivalents per liter. If you're giving 50 cc's and this material, then when you convert it out, it basically comes out to be around 24 to 25 milliequivalents in this individual. And if you look at overall, it actually will increase the sodium in the serum by about 7 to 9 millimoles per liter. The other way of treating this is by giving a person 6 milliliters per kilo of 3% normal saline. These are the initial studies we're using. It increases the sodium usually about 5 to 6 millimoles per liter, so it's a little bit slower, but it requires a little bit larger volume, usually 100 cc's of 3% normal saline over 10 minutes. And sometimes an additional 2 boluses if symptoms continue have been used to basically reverse the severe hyponatremia, which is able to cause the seizures. Now, after you've done that, what I would recommend you do is do slow correction after the emergency. So let's say you start your current plasma sodium is like 115, and the person's actively seizing. Your target range is only 5 milliequivalents higher than that. Usually, that's good enough to stop the seizures. If you look at the sodium deficit, which is around 5 milliequivalents per liter, and you look at the total body sodium deficit, which is, remember, your total body weight in these individuals is going to be, and say we're using a 50 kilogram patient, 5 milliequivalents per liter times 0.5 percent total body weight times, this is for a woman, times 50 kilograms is 125 milliequivalents. So basically you want to replace 125 milliequivalents. If you look at the amount in 3% normal saline it contains, is 513 milliequivalents per liter. When you convert it out, 125 milliequivalents times 1 liter divided by 513 milliequivalents, that's going to give you the volume that you need, which is about 0.24 liters or 240 cc's. So what you do in this situation is you infuse this to not exceed 0.5 milliequivalents per hour over 10 hours. So you give about 24 cc's per hour for 10 hours. So, and that actually will reverse the problem. Okay, that's another way of actually dealing with it over time. The other recommended dose was what I was showing you before, which is the more rapid method for somebody who's actively seizing. Be careful not to overdo it so you don't get into the actual demyelination problems. As what you should do for anesthesia is you should correct prior to elective case, especially if symptomatic. Consider placing an AIM line. Do not do frequent sodium measurements during the case, and there's an increased incidence of hypotension during induction and maintenance in these individuals, so be careful as well. Now the next set of problems is hypernatremia. Let's go the other way. Hypernatremia is considered serum sodium above 145 milliequivalents per liter. This is fairly uncommon because usually it's due to water deficit or excessive sodium intake. Usually it's because somebody's giving the person prolonged normal saline, which is a member that has 154 milliequivalents per liter sodium. There's 3 categories of hypernatremia. You can actually have your hypovolemic, euvolemic, or hypervolemic hypernatremia. Hypernatremia invariably is accompanied by hyperosmolarity and always causes cellular dehydration and shrinkage because it begins to extract the waters out of the intracellular space. This is the different forms of hypernatremia. I can show you that you either have hypovolemic or hypervolemic. If you look at your hypovolemic hypernatremia, it's usually you'll pick it up fairly easily because the skin turgor is decreased. You have flat neck veins. You have orthostatic hypotension. You then should look at your urine sodium concentrations. If the urine is spilling sodium in that situation, it could be from renal losses and water losses. Things like osmotic diuretics, loop diuretics, or postrenal obstruction are causes of this form of hypernatremia. If you have serum sodiums of less than 20, would indicate extrarenal assault and water loss, which leads to things like diarrhea, GI fistulas, burns, and sweating. If you're looking at the euvolemia, things like diabetes insipidus from water loss, or extrarenal water losses or insensible losses from the respiratory tract and skin. If you look at the hypervolemia, these patients have peripheral edema. Their urine sodium concentration usually is greater than 20, and you get sodium gain still, despite this. Things like hyperaldosteronemia, Cushing's, hypertonic dialysis, intravenous sodium bicarb, which a lot of people forget. The sodium bicarb has a high amount of sodium in it. Sodium tablets for like in military use against dehydration. Signs and symptoms of hypernatremia are severe thirst. This activates the thirst centers in the body, so the person will develop polyuria and polydipsia. They also will develop orthostasis as part of the symptoms, and restlessness, irritability, and lethargy. As for your signs, the person will develop muscle twitching, hyperreflexia, tremors, ataxia, muscle spasticity. Due to the excessive high gradients of sodium, you get overstimulation and overactivation of the actual set sodium channels. You can also look at focal and generalized seizures may occur, and death if dehydration of the brain occurs. Treatment of hypernatremia depends on the situation. If you're hypovolemic and hypernatremic, you need basically replace water deficits with normal saline, or give lactated ringers, which are in a little bit less value. Once you're euvolemic, give hypotonic saline or 5% dextrose. You basically don't want to correct too quickly, which may actually result in cerebral edema. Because remember, if you give a person free water, it's going to basically go right to the brain and cause cerebral edema. That's why they usually recommend starting off with normal saline initially, so you don't get this effect where the water redistributes and leaves the brain high and dry and get in a worse situation. If you have a patient with euvolemic hypernatremia, you get hypotonic saline in these individuals or 5% dextrose. If you're looking at hypervolemic hypernatremia, then patients may respond to diuretics such as Lasix and spironolactone or dialysis. Treatment in the acute setting should be corrected over several hours. As for the chronic patient who comes in, it should be corrected slowly over days. So really, for elective surgery, you shouldn't take a chronically ill patient with significant hypernatremia and beginning to try to reverse it almost immediately. That's not a good idea. Instead, go more of a slow approach. Remember that you have an increased risk of developing cerebral edema when you try to give fluids, because the blood-brain barrier takes a little bit of time to adjust. So if you start giving these people a lot of free fluid into the intravascular volume, this water will follow where the salt is. This individual may develop edema in the brain as a consequence. Hypokalemia is the next electrolyte disorder. We've talked about this previously, so I'm going to go over it a little bit more briefly. Remember that the normal potassium that becomes hypokalemic is less than 3.5 milliequivalents per liter. Remember that 98% of potassium is found intracellularly, and that's where potassium usually is found very happy. The actual intracellular potassium levels are usually 150 milliequivalents per liter. If you look at a 50 kilogram patient, the intracellular compartment is 40%. If you look at the actual calculation, it's 20 liters times 150 milliequivalents per liter for a 50 kilogram patient, and that basically gives you 1,000 milliequivalents of potassium inside the cells. Versus if you look at the intravascular or extracellular compartment, which compounds for the other 20%, you're looking at only 40 milliequivalents total of potassium in that whole space. That includes your intravascular and your interstitial space. It's actually hypokalemia is considered the most common electrolyte disturbance, and it's found in around 20% of patients that actually have been hospitalized. Chronic hypokalemia may cause actually a massive total body deficit of potassium by around 600 to 800 milliequivalents, or basically 1 milliequivalent per liter in deficit. Hypokalemia can be preoperatively induced from stress. Agents that are given to patients such as beta agonists may also induce more rapid influx of potassium into the cell. You can also have chronic versus acute in the perioperative period. May be significant in how fast you want to correct this. What you end up seeing with hypokalemia is EKG changes, which is eventual problems with myocardial depression. Because cardiac-wise, you see abrupt changes and more pronounced alterations such as dysrhythmias. Usually with hypokalemia, you tend to go into tachydysrhythmias, specifically atrial fibrillation. It also is found to have potentiated digoxin toxicity in individuals. And you have an increase in sodium reabsorption, which leads to hypertension. These patients very often present with orthostatic hypotension. And EKGs show U waves, PR elevations in PR intervals, ST segment depression, inverted T waves, and increased automaticity, including V-tach. Skeletal muscle will become weak, and they'll have cramps and paralysis, and smooth muscle does the same. So here's your patient with EKG changes. You can see that you have a prominent U wave, but you have a very shallow T wave. And you can see the downward trend in the ST segments in this individual's disease, such as hypokalemia. Hypokalemia is caused by either excessive renal loss, potassium loss into the GI tract, and also by inability for the cells potassium to stay inside the intravascular space, and it's pulled back into the cell. So there's different causes of hypokalemia. If you look at potassium loss, almost always it's usually drug-induced from drugs like thiazides, loop diuretics, mineralocorticoids. Sometimes high-dose glucocorticoids can also do this, as well as high doses of antibiotics like penicillins, and your magnesium depletion from, again, things like aminoglycosides, which are antibiotics. Patients that also may significant loss due to surgical trauma, hyperaldosteronism, leukemia, hyperglycemia, and uncontrolled diabetes may also account for this. The other causes of hypokalemia include GI losses from diarrhea and vomiting. If you have the ZE syndrome, it may also cause it, Zollinger-Ellison syndrome. If a patient may have jejunal ileal bypass, you may have conditions where you have malabsorption syndromes, chemo, where a person gets excessive amounts of nausea, vomiting, may also induce hypokalemia. The other form of hypokalemia is a transcellular potassium shift. This is actually something that we use all the time if we have a situation where the patient is becoming acutely symptomatic of hyperkalemia. We use these normal pathways to reverse that effect and to push the potassium back into the cell. But these are normal processes that may also be contributive to hypokalemia. Things that actually will increase the transfer of potassium into the cell are beta agonists, such as epinephrine, pseudoephedrine, ephedrine, isoproterenol, albuterol, or terbutaline. Other things that besides the beta agents are things like tocolytics, verapamil, and insulin are also one of those critical agents in trying to cause more potassium to shift into the cell and causing acute hypokalemia. The other things that will also cause this effect is insulin and combined with glucose. It's a Symport system which will also pull potassium into the cell. Alkalosis of any kind, either metabolic or respiratory, will induce potassium to shift into the cell. If you hyperventilate a patient on induction, a lot of times you'll notice that the person will develop this tachydysrhythmia. If you look at it more closely, it could be atrial fibrillation, which is very commonly associated with hypokalemia. The other reasons that why you develop hypokalemia will be a rapid loss in sodium, such as in diseases like familial periodic paralysis. Where you see it is hypercalcemia, hypomagnesemia, and things like stress-induced hypokalemia may also occur. Treatment is to consider total body potassium, magnesium. PL supplementation is still safer so safer than the IV by far. IV is risk of inducing dysrhythmias, including overdoing it and causing hyperkalemia to develop in asystole as a consequence. More aggressive treatment is usually seen for treatment of DIG toxicity. The actual IV dose supplementation of potassium should never exceed 20 milliequivalents per hour. So that's a good test question that I expect you to know. Potassium-sparing diuretics such as amiloride and spironolactone may also be helpful in treating uh, hypokalemia, not so much for treating it, but rather to maintain diuresis, but without causing potassium wastage. And then you have your mag deficits is very clearly important and should be corrected prior to trying to correct your hypokalemia, as it will not correct until magnesium levels are more normalized. The other side of it is hyperkalemia. Hyperkalemia is situations where your serum potassium levels are greater than 5.5 milliequivalents per liter. Signs and symptoms that you see is a loss of potassium gradient. And remember, the cardiac-wise, you lose your gradient and you will basically go asystole. Initially, you'll see a prolongation in the PR interval, followed by loss of P waves, where you get wide QRS, you get tall peak T waves, and then you go into VTAC, VFib, and eventually you go asystolic. This hyperkalemia will affect both cardiac cells and your muscle cells, so you got to be careful in the sense that you can't. You want to avoid giving somebody very high doses of potassium. Skeletal muscle weakness can cause paralysis. The actual big concern, of course, is cardioplegic solutions, as they give high doses of potassium, and they do induce muscle paralysis, including cardiac standstill. The things that you'll see in hyperkalemic arrest is that you see an elevation in T waves, which is called peak T waves, and eventually you get a prolongation of the QRS interval. Eventually you develop a sinusoidal pattern, and it goes into a systolic pattern. Causes of hyperkalemia can include potassium retention, things like renal failure, hypoaldosteronism, drugs that impair potassium excretion, beta blockers, things that inhibit the renin-angiotensin-aldosterone system, such as ACE inhibitors and angiotensin receptor blockers, and patients that receive excessive blood transfusions, especially older blood transfusions that contain lyse cells inside them, which cause the elevation of the potassium levels. You can also get from transcellular shifts from drugs such as succinylcholine. Patients that are developing acidosis may also cause a transcellular shift, driving potassium out of the cells. You get chemotherapy and lysis of cells may be seen as well in the floors for oncology. And you may also get, of course, iatrogenic boluses, which are very dangerous. That's why you should maintain your maximum bolus of 20 milliequivalents per hour. Pseudohyperkalemia be hemolysis from blood specimen, and thrombocytosis and leukocytosis can also induce this. Remember that aldosterone is ultimately responsible for sodium retention, but also increases potassium excretion. So if you have elevations in aldosterone, you should have more wasting of potassium. On the other hand, if you get a loss of this, you will not get as much reabsorption of sodium, and as a consequence won't waste the potassium, and it'll be held in. Hyperkalemia is usually treated by cardiac protection first, so giving calcium, usually calcium chloride in these individuals, followed by transcellular shifting the potassium back into the cells. This can be done by hyperventilation or followed by sodium bicarbonate treatment, and glucose insulin and beta-2 agonists are also used for bronchodilators. You may also want to eliminate the actual potassium availability by giving agents that actually bind to potassium inside the GI tract. So things like ion exchange resins. Lasix and dialysis are also very helpful in removing potassium out of the cells, out of the blood, and basically make sure you avoid lactated ringers in these individuals. Perioperatively, if your potassium is less than 5.5, it's still okay for elective surgery. Watch controlled ventilation to avoid respiratory acidosis. These people are not appropriate to start letting them spontaneously breathe and get hypercarbic and cause a respiratory acidosis as the potassium levels and as a consequence rise and make the person become symptomatic in the hyperkalemic range. Potassium increases of 0.3 to 0.5 up to 1 milligram per liter is seen with succinylcholine and is still considered safe as long as the potassium is less than 5.5. Basically, if you do get in trouble, you need to ameliorate and treat in emergencies and basically recover, like we talked about in the previous slide on how to treat hyperkalemia. As for pseudohyperkalemia, this is a lab anomaly caused by potassium release from platelets and leukocytes in the test tube. This is not really a true hyperkalemia. The best way to do it is by rechecking your labs. Your serum potassium levels and plasma potassium levels your serum potassium levels are elevated, but your plasma potassium levels are normal. Hemolysis is also increased measured potassium in the lab. So you got to just look at and sometimes you have to redo your test if you see this. Hypocalcemia is the next discussion. I'll sit here for a second and I'll return to this lecture in a minute.